Hello, and welcome to a very special briefcase that is part of a series I'm leading on diversity, equity, and inclusivity with CME Outfitters. Today's CMEO briefcase is entitled Gastroenterology Care, Real-World Tactics to Address Health Inequities. Today's program is supported by an educational grant from Johnson & Johnson. I'm Dr. Monica Peak, and I'm the Ellen H. Block Professor of Health Justice in the Department of Medicine at the University of Chicago, where I also serve as the Associate Director of the Chicago Center for Diabetes Translation Research and the Director of Research at the McLean Center for Clinical Medical Ethics. I am delighted to be joined today by my distinguished colleague, Dr. Sandra Quezada. Sandra, if you wouldn't mind introducing yourself.
Hi, absolutely. Thank you so much, Dr. Peak. Thank you for having me. I'm Sandra Quezada. I'm the Associate Dean for Admissions and Associate Dean for Faculty Diversity and Inclusion, as well as a gastroenterologist, Associate Professor of Medicine in the Division of Gastroenterology and Hepatology at the University of Maryland School of Medicine. And I'm excited to be part of this program.
Thank you so much. You're bringing a wealth of expertise about everything that we're talking about today, so I'm really excited to have you here. So let's get started. Our first learning objective today is to identify the impact of health inequities on gastroenterology care. But before we get started, I do want to remind our audience that this CMEO briefcase is a continuation of our initiative to address unconscious bias, health disparities, and racial inequities. We're building a comprehensive library of educational activities addressing these important issues. And today's activity continues the discussion in gastroenterology care. On this slide are the titles of other activities in this series with links to each of them. To view any of these programs, simply click on the activity title. If you participate in at least 3 of the programs in our D&I Hub, you will also be eligible to receive a digital badge demonstrating your commitment to education on diversity, equity, and inclusivity. So Sandra, let's get to it. What can you tell us about our first patient today?
Yes, absolutely. So our patient's name is Michael. He's a 24-year-old African-American gentleman with a history of ulcerative colitis that was diagnosed 2 years ago. At the time, he was having some abdominal pain and noticed blood in his stool. And like most of us would be concerned, he was appropriately concerned and went to see his primary care doctor, who, he was a young guy at the time. He was a 22-year-old gentleman, and his primary care said, "I'm sure that's just hemorrhoids." But unfortunately, Michael really felt kind of dismissed, and like his primary care doc wasn't really listening to him and appreciating the level of concern that he had. His symptoms continued to progress, and so eventually his primary care doctor did refer him to see a gastroenterologist. He underwent a colonoscopic evaluation and got diagnosed at that time. But then he really only followed up once to see the gastroenterologist after his diagnosis. And then because of missing 2 of his appointments, and at the time he also was supposed to get some lab work done, and that didn't happen, he actually got discharged from the GI practice. And there really wasn't any record in his, any explanation in the medical record as to why he had to miss those appointments. And unfortunately, so he has been now just on maintenance with sulfasalazine, 1 gram twice a day, and gets flares every couple of weeks in the last year or so. And so when he flares, he gets prednisone 40 milligrams daily for 1 week. And the last flare just happened 3 weeks ago.
That sounds about like the worst kind of care I can imagine. So let me ask the audience a question before we dive deeper into this case. So the question is, which of the following is a potential downstream effect of health inequities in a patient with IBD? So you can go ahead and vote now. Okay, so Sandra, what are your thoughts about the correct answer? Can you walk us through that?
Yeah, absolutely. The correct answer here is B, more frequent use of steroids during disease management, particularly with IBD. And this really reflects several downstream effects of healthcare inequity. This is what happens when we aren't necessarily giving equal and equitable access to higher level therapies like biologic therapies, for example, to patients. And it's been shown actually in studies over and over again, both in terms of socioeconomic status as well as racial disparity studies in IBD and even in rheumatology, that biologic therapy hasn't been prescribed equally across different groups. And as a result of that, patients are flaring and they are more likely, unfortunately, to get steroids, which we all know is not the ideal long-term management or solution for really any inflammatory condition. And we have better medications, and someone who needed steroids and was flaring as often as our patient Michael was really should have been considered to step up to something that really is more appropriate for the level of disease activity that he has.
Mm-hmm. Absolutely. So I'm thinking that he's going to be at higher risk for diabetes and other steroid related complications, that with his amount of severity, he's going to have more complications from his IBD because it's not being controlled as well. Just the level of pain and suffering and the quality of life, how many days he's going to be missed off work, what implications that may have for his family. He may have lost his job, just all of these things because he has been locked out of the GI clinic and his primary care physician is kind of frozen with this management plan. And that is not a unique situation. I know that you know. So let's talk more about this case, and I'm hoping it's going to get better.
Yes. So Michael's been busy. Michael is an emergency medical technician. He has long shifts. He works 12-hour shifts that could be daytime, overnight schedules. And unsurprisingly, in the setting and the clinical context that he's been dealing with, he's got fatigue, he's not been sleeping well, and he's experiencing stress and anxiety about his ulcerative colitis symptoms. He's been attributing a lot of his symptoms to the fact that his, sleep schedule and stress related to his job is really impacting his health. And he also has had some difficulty in getting really consistent and timely access to a bathroom at work, which any patient with IBD understands how important that is to have that access. And he just hasn't been comfortable having that conversation with his employer. He hasn't really wanted to have that level of private discussion or even feel like it makes sense for him to ask for any kind of special treatment. He doesn't want to stand out in that way. So he's really avoided having that conversation with his employer. So he intermittently has needed sometimes time off work so that he could make appointments, but he was not able to get that as a result of, just again, not being able to feel comfortable expressing those needs. And so then this is really the explanation for the missed appointments and inability to get labs done. And he's also really concerned about the costs of the lab work and potentially of, future colonoscopic evaluation. And how much coverage his insurance really is going to give him. So, he even mentioned that, he said he waited months just to see a GI doc. And then when he got there, he felt like they really didn't want to listen to him. They just wanted to kind of give him the prescription and kind of send him away and say, come back in 30 days. And he just didn't like the interaction and didn't obviously feel that it was valuable or should be prioritized. And so lab work, therefore, hasn't been rechecked since the initial diagnosis a few years ago. And he also has never been offered a biologic or any other option, small molecule therapy for ulcerative colitis from the gastroenterologist, the one gastroenterologist that he saw.
So many issues there to unpack, and we've talked about many of them already, that we sort of forecasted these stories about reasons why he may have missed appointments, some of the complications. And I think one thing that's important for us to talk about is his inability to discuss this with his employer and what that has actually meant for his health long term. And so when we talk about structural inequities in healthcare, what we primarily think about is what we can do as healthcare providers in that healthcare space, not necessarily thinking about the fact that that person with these chronic diseases, particularly if they're one that have stigma associated with them, or the person perceives there's some stigma or some sensitivity around talking about it, that they're carrying that same experience, not just in the healthcare system, but wherever they go, including their workspace. And so, the same structural racism that we're trying to avoid in the healthcare system, they're living that in their regular life. And so if there are power inequities, because of the type of work they have, or they don't feel as empowered to speak up with their bosses, or they may have different, some shift change because of who's the manager on at that time. They may just not be in a space to navigate that as well as others. And apparently he hasn't been able to. And so what we might need to do as providers is to keep that in our head and be more proactive and saying, hey, do you need, how can I help you as a physician in your workplace to make sure that you get all the things that you need to make sure that our health plan right here can be put in place. And one of the other things that I noticed when I send my patients to a subspecialist a lot is they're sort of expecting the kind of safe and cozy environment that I've created because I've known them for years. And then they go see someone who they don't know, who is super specialized, but, isn't giving them all of this like fuzzy love. And they come back and they're like, well, that wasn't,
Yeah.
And so then they don't want to go back. And I'm like, but they're, and so there's all of these things that sometimes create disconnects that we have to be aware of when we are welcoming new patients into subspecialty care, from primary care, as they need to go on into other spaces that will help them enact the complicated plans of care that we have for them, that will make a difference in their morbidity and mortality.
It's really helpful and important. We often have a tendency to think about patient level factors and just sort of, what's going on with the patient, which is important. We need to certainly incorporate that as well, but we also need to step back and think more broadly, like you're saying, and what are the system level factors that are also creating an environment such that you're really not enabling the patient to participate and engage in the best way possible. So I think it really is important to recognize that there is the disease process, but there's like everything else in your patient's life that's also happening that really strongly influences and impacts how they're able to manage their disease, and ultimately is going to change outcomes.
Absolutely. Absolutely. And that's something I think that's critical for us to all think about for the patient that is in front of us, but then for populations in general. I also just want to remind our audience that that we have this long history of systemic racism that has led us to where we are now. And we have a number of programs that address historical and structural racism. So I'm not going to cover all that in depth today, but I just want to remind our audience that long-standing historical racism has led to unequal access to things like education and employment, safe housing and healthy food. It's also led to unequal access to healthcare and differential treatment within the healthcare systems. And so that chronic stress of racism has been so toxic that has altered the biology and the DNA of people exposed to it. So leading to elevations of cortisol, autonomic dysregulations, HPA dysfunction, and epigenetic changes and more. And this has been a major contributor to the higher burden of chronic disease amongst racially minoritized communities, who ironically then have to turn to the very systems for healthcare that have contributed to so much trauma. And so the distrust of providers and healthcare systems is based on history, but it's also based on the daily treatment of practices within our healthcare system. So working to address interpersonal bias as well as structural racism really is a must if we're truly to make advances towards racial health equity. And so we need to start by doing things like just really listening to our patients with issues that matter, like Michael, who fell out of care initially because he didn't feel listened to. So Sandra, can you share some specific data on disparities in the care of patients with inflammatory bowel disease?
Sure, absolutely. And these are honestly, they're so disappointing to see. And this is mostly from data from some studies that some of them took place even 12 years ago, and then some more recent ones haven't shown as much difference as we would like to see. But what we know is that in IBD, African American or Black patients are less likely to have annual visits with a gastroenterologist. And even within gastroenterology, we have IBD subspecialists. And those of us who are IBD subspecialists really want to take ownership for our patients. And we often see, especially if they're on a biologic therapy, for example, we want to see them 3 to 4 times a year, not even just annually. And so that's like the bare minimum, and Black patients are less likely to even reach that bare minimum. As I mentioned earlier, they're less likely to be prescribed a biologic agent earlier on in their IBD course, which more and more we're recognizing you don't really want to wait and kind of let things continue to progress and reach a threshold at which you've really kind of delayed the treatment that ultimately the patient needed. We're trying to stratify our patients such that we recognize this patient really needs to be on this biologic therapy sooner rather than later.
Yes.
And I will say that when we talk about system, insurance companies are not helping us out. There's a lot of denial and prior authorization work and things that are barriers, basically system barriers that are being put up to delay those therapies. But nonetheless, as their physician, it's our job to advocate for our patients and make sure that we're doing everything we possibly can to give them the access to those drugs. And Black patients are twice as likely compared to white patients to require treatment in the emergency department. Meanwhile, as far as what happens more often we see higher hospitalization rates, lengths of stay when they are hospitalized, increased costs and readmissions. And one thing I'll say that I think is a really important thing to stress here when we talk about these disparities that we see across race is that we have to recognize that race doesn't exist in a vacuum, right? And just as we've been saying, there are all these system level factors, these social determinants that are driving these disparities that we see inherently because race is a social construct. When we see differences and disparities across race, what we're primarily seeing is difference that's driven by social inequity and systemic inequity. And there actually have been some interesting studies where they really are trying to tease out the effect of social economic factors and race. And what we've seen is, for example, when we talk about the biologic access, if you can actually control for access, say with insurance, there have been a couple studies that have shown that access to biologic medication doesn't differ across race when there's actually truly equal access, such as if you're looking at a restricted Medicaid cohort, which one study did, and they found that there was no difference there. There's a Canadian study where, in Canada, everybody has some level of, healthcare coverage that provides access to biologic. And again, and this was actually across socioeconomic status, there was no difference in terms of biologic use across different socioeconomic strata. So I think that that's an important point too. I think it's also important to highlight that all the differences are also not just access. Sometimes they're, I think that the race portion, even if you adjust for socioeconomic status, there is still systemic racism there that these communities experience, our communities experience. But I think that it bears mentioning that, again, race and all of the social implications that come with identifying and being part of a certain ethnic or racial community are complex, and that we don't want to oversimplify what the underlying causes are, because then we're not going to be able to figure out how we're going to fix the problem. And people historically have used race incorrectly as a biologic term and thought, look, maybe there's some, there's a biologic genetic predisposition, and this is why we're seeing some of these problems. But again, it's important to emphasize how important social determinants are really driving these differences.
Absolutely. It's that it's this odd thing that race is a social determinant, but its exposure to racism that
Yes.
creates the biological differences. So if you do see biological differences, it's not because people started out with brown skin, it's the stressors of racism that has created those differences. And so you want to be able to point to the source of the etiology. And it's not the fact that people have melanin, it's the fact that they've been exposed to these chronic toxic stressors. So thank you for that that lovely sort of discussion about race and class, and thinking about them differently, and the social determinants of health and how they can impact things like missed appointments and non-adherence to care because the insurance is poorly covering these medications because they want to squeeze as much, profit out of them before, they go generic. Despite the fact that people are suffering and getting complications of the disease while they're waiting. And so there are so many things that disproportionately burden persons that are racially minoritized, that are at the systemic level, but that impact individual patients that we have. Because one of the things that we know is that only 20% of the medical care we deliver impacts health. The other 80% are these social determinants of health. And so we have to be thinking more broadly about things like access to the expensive medications that we're trying to prescribe. If they miss an appointment, are we going to go chase them down and bring them back in, and think about why they missed that appointment? Because we know how critical it is. Are we going to bring the family in because, it takes a village to do anything? Are we going to think about, issues of food security and housing stability and how those might be more pressing priorities for how people are spending their money, and get a caseworker involved so that those issues can be addressed. People can have the peace of mind to then think about these, important but expensive medications. And so, addressing these social determinants is so important for everyday life, but particularly for those chronic diseases that really hinge on the being able to utilize expensive, but life changing medications. So, Sandra, do you have anything else to add about social determinants of health?
Absolutely. I mean, I think to your point about when we recognize that this 80% of these outcomes are being driven by social determinants versus our, 20% that we're fighting for in the clinic space. And it just really, I think, is a call for all of us to think about how can we incorporate this understanding of how important social determinants are into our everyday practice. What can we be doing differently because of the fact that we know that this is important? And so I personally think I'm really, really fortunate and blessed and privileged in many ways because I'm in an academic institution. And over time, what we've been able to do is to grow our care team to make it multidisciplinary so that in addition to the gastroenterologists, we do have, the first person we added was a social worker. And then we also added a nutritionist. And then more recently, we added an IBD pharmacist. So between all of these individuals, we've been able to take a sort of, with fresh perspective, a multidisciplinary approach to make sure that we really are addressing the needs, the many needs a patient may have in order to, again, make sure because of, being of a minoritized group, because of all of the barriers that they're coming up against, how can we support them? How can we potentially help them overcome some of those barriers? One of the other things that I think is really important is being explicit and vocal about recognizing and understanding that that we have not done our duty as a medical profession to make it easy to see specialists, to get the medications that you need, and that we are trying to do something different now. We're doing something better, hopefully, and that we're also going outside of our comfort zone and just being in the clinic space, but actually advocating and engaging legislators to change policy so that these barriers that currently exist don't continue to perpetuate these disparities. I mean, you mentioned that, it's these racist system level policies that brought us here. And I feel like new policy is what we need to move to a new place from where we are. And then the last part is specifically for anyone with IBD patients, and particularly IBD patients of color. There's a wonderful, there are many wonderful organizations, but one of my favorite ones is called the Color of Crohn's and Chronic Illness. We affectionately call COCHI. And this is an excellent, really, I would argue, like a peer support group for patients with ulcerative colitis, Crohn's disease, and other chronic inflammatory conditions, and with a unique focus in being a space for patients of color, particularly Black and Brown patients with IBD, who oftentimes feel like they're the only person that they know with IBD. And oftentimes, unfortunately, because of the way it's depicted in TV commercials and other things, they think that this is a white person's disease. Right. And it's not. It's actually anybody can have IBD. And unfortunately, I think even we were probably taught to think that too. It's important to recognize IBD is global. It's all over the world, and patients of all colors and backgrounds and ethnicities and races can have IBD. And most importantly, I think it's important for patients to see that as well. And so this particular group is just fantastic in, kind of raising that visibility, creating community for Black and Brown patients with IBD. So that's another thing I'm doing differently now, is making sure that in addition to the service that we can provide, recognize there's nothing like having a peer, and also just having that community of support and learning some lessons from each other.
Excellent. Excellent. Thank you so much for just creating space in your own practice that we can all learn from. One other thing I want to ask you about is the AGA Equity Project, because I know you're involved in that.
Yes, and this is one example. Fortunately, I think all 5 GI societies really have made a concerted effort, but I'm particularly proud of the Equity Project and the AGA, which is essentially a 3-year equity strategic plan designed to really think about how we can promote equity, both for the GI workforce, which itself is becoming more diverse, and yet we're not always seeing, say, promotion and leadership being equitable, seeing representation in that space. And also recognizing that we need to do a better job in terms of learning about what disparities in GI exist. We've been talking about IBD disparities, but unfortunately, they're across all GI diseases. So really increasing awareness and education. And some of our goals and achievements have been increasing fundraising for GI health disparities, supporting young investigators in particular who are either from diverse backgrounds or who are really doing wonderful health equity research. And I mentioned engaging legislature. We've had 3, actually it's been more than that now, many congressional briefings to really raise awareness and hopefully support to address these inequities.
Excellent. Thank you so much for all of the work that you're doing, both in your practice and nationally. This is fabulous and important work for all people, but particularly those who have been marginalized with their experiences. You're a blessing. So we're going to move on to our second learning objective, which is to individualize treatment strategies that include the assessment of social determinants of health to improve patient outcomes. One important step in addressing those social determinants is actually talking to our patients, listening to their needs, engaging them in the discussion regarding the management of their disease in a way that meets patients where they are with the realities of their life, work, and social support systems, and what we call shared decision-making. And that's something that actually is an area of focus for me in my research. I'm primarily a diabetes researcher, but it's true for any chronic disease where people are making decisions over time. It's true for any disease, but I think it's particularly helpful for chronic diseases where there are a lot of micro treatment, micro decisions over time. And so really understanding, what are people's life preferences, what kind of support systems they have, making sure that they understand all the options, the pros and cons, and most importantly, that they feel heard and that they feel on board with the plan at the end of the day. And so there are lots of different ways to sort of get there. And because we're kind of short on time, I'm going to sort of refer people to some of the resources that we have. But the most important thing is to make people feel a part, an active part of the process, and from the beginning all the way through the end. And at the end, to make sure that they feel confident that they and their family can implement this plan of care, and they feel like you as a provider are a trusted partner in this process. And I think that is where we are going to make sure that we haven't dropped the ball, that the person is going to get the labs, go for the colonoscopy, come back for the next visit. And if we don't have those things, that's where we start seeing some of the barriers sort of manifest that we haven't been able to address, and that you are addressing with your treatment plan. And some of that involves, like you said, having multidisciplinary treatment teams that can make sure that we are addressing the needs that come up. So when people are sharing with us aspects of their life, that we have responses to those. And so you talked a lot about that in your practice already, but maybe you can just sort of briefly talk a little bit about the multidisciplinary treatment strategies.
Oh, absolutely. I always love to really praise our team, because it's no doubt or question that we wouldn't accomplish what we do without, for example, having our social worker and our pharmacist, and just having our social worker also actually has the ability to provide some counseling and some mental health counseling, which is also a really important thing to think about. And we see overrepresented, unfortunately, in our IBD patients. So really, I think just especially I see here, that with outreach and networking and information sharing, these things are so important. Actually, our multidisciplinary team helps with all of those elements as well, and especially with care coordination and making sure that we're all on the same page, and most importantly, that we're on the same page with our patient. And that we're truly addressing the many needs that need to be met in order for our patient to be able to get the medication that they need, feel good about the fact that they have it, that they can take it, and keep their appointments.
Great.
And I think that one thing I really like is thinking about having some kind of a plan. If we don't have a plan, like for many things, then we're just sort of haphazardly going about our day, and we typically tend to recreate the same problems that we have, unless we really are intentional in terms of thinking how we can do things differently. And I think one important thing to do is look at your data and kind of go back, and you cannot do this if you have an electronic health record, it's easier. But to go back and look and see if there are some differences. We talked about disparities in biologic treatment, for example, or adherence to appointments. It would be, I think, really useful to go back and look and see, are there differences in my own patient base with respect to how I'm prescribing medication, or with respect to any of the potential barriers. And now you have a target, right? Now you have something specific that you can address that will make life better for at least some, if not many, of your patients potentially. And I think it's important to recognize that there are community partners as well, that we're not in this alone, and actually will be much more effective if we do partner with community leaders and also with those resources in the community that are so important and valuable to so many of our patients.
It takes a village. And now more and more we have the health information technology that can sync up our electronic medical records with community-based resources based on patient needs. And so we're being more and more able to do so from the healthcare perspective. So thank you so much for all of that information and the resources and the passion and your examples. We're going to go back to the case and see how Michael's doing. What were the next steps with him?
Yes. So Michael finally did fortunately get to follow up with the gastroenterologist, got a colonoscopy, and it was seen that there was some moderate disease activity in the colon, and his labs were pretty clear that there's active inflammation. He's even anemic, and that he's not being adequately treated with the therapy that he's been getting. Not to mention the fact that just some frequent prednisone is never a good thing for anyone. And so, so there's a conversation about what are the goals of the patient. I think when we talk about meeting patients where they are, I think one of the important things to ask are, what are your goals? I know what my goals are when I walk in, but just being thoughtful about what the patient is prioritizing, what's important for them. And then certainly in terms of treatment goals, and we can share that, we want you to feel better, right? We want to make your symptoms go away so you can live your life and not have to constantly be thinking about your diagnosis. Ideally, we'll see some objective marker of improvement. So the inflammatory markers we would want to see get better over time when we get you on the right treatment, and that we can even see evidence of healing. When we repeat a colonoscopy, which we often do when we start a biologic therapy, that we'll see evidence that it's working because the inflammation is gone and there's actual healing in the gut. And I think that's an important thing to stress for patients is, we don't just think you feel better. We can really see objective measures that you really are doing better.
And for people like Michael who've been sort of off or who've never had biologics for such a long period of time and had these symptoms and presumably scarring, and he may have had, who knows, complications and ER visits and fistula, who knows. How effective can instituting biological agent be at this point as far as healing?
Life-changing. Really, honestly, I've seen wonderful turnaround from patients who were even hospitalized we're talking about colectomy. We're at the point where we have colorectal surgeons consulting, and there's that possibility. And then we give them that first dose of biologic, and they're out of the hospital in a couple days, sometimes as early as a couple days, if not definitely by a week. We can actually really save colons and allow patients to keep their colon and stay healthy. So it's pretty impressive. All of that said, it's really unfortunate that it would have to get to that point, right? Like, we don't want necessarily for somebody to be that far gone, but when we're having that first conversation. But it really is important, I think, to stress how effective these medications really can be for many patients.
And how high the stakes are.
Absolutely.
How
Right.
different the outcomes can be.
Yeah. So people are always concerned, and I think it's important to have this conversation about the risks of the therapy, but then we also have to talk about the risks of not pursuing that therapy and what will be an outcome of that.
So before we ask you about the specifics of treatment, let's see what our audience is thinking at this point. So you should see the questions on your screen. You can answer now. The question is, based on what you know about Michael so far, which of the following treatment regimens do you think would be the best for Michael? Okay, so Sandra, people have voted, and the correct answer is B. What are your thoughts?
Yeah, so I think it's fun. It's a little bit of a trick question because I mentioned earlier how important it is to have that shared decision making, and what we haven't shared with you here or with the audience is, what did Michael say when I asked him what his goals are, and specifically, I think one of the important things, we have such a wonderful array now of different options and different methods of administration, and so also getting a sense of what your patient's preference may be. Some patients love the idea of an IV infusion that they only have to do every 2 months, and the 2 months in between, they don't have to think about it. And then they come back and they sit for a few hours and get their infusion and then go back about their day. There are some patients who love that, and infliximab is a reasonable choice here if there's a patient who is really interested in that. Oral budesonide is, it's a localized steroid, essentially. It's a topical steroid. And I would argue in this case, we've already seen that that's really not the ideal long-term choice for this patient. And it probably wouldn't be enough anyway. We really need to kind of step it up. Tofacitinib is a great medication for ulcerative colitis, and it's an oral medication, which many patients might be interested in. But the caveat here is that it's approved for ulcerative colitis only after you've failed another biologic treatment. So it's actually not an option for Michael right now because the only other thing he's had is sulfasalazine. So I would say it's between A and B, depending on what Michael says. And in this case, for all of you who thought B, you are correct, because Michael really is thinking about that convenience factor, his really difficult shifts with work that could be overnight, et cetera. And, even though ustekinumab, the first dose is an IV, later, then it's all injection that he can do at home, and he can really have that convenience and autonomy in planning his doses.
So all of that sounds great, Sandra. Can you tell us just a little bit more about how you would fully manage Michael?
Yes, in fact, as I mentioned, one of the things that you want to do as you're considering changing therapy, and especially since he's been having these flare symptoms, with ulcerative colitis, we often do repeat a colonoscopy. We want to make sure that we're not missing potentially overlapping disease processes. We usually get biopsies. We can rule out infections that can also either present as a flare or just exacerbate flares. So he did get a colonoscopy, which was consistent with an ulcerative colitis flare. And so that's when we really got the chance to sit down and talk then about what the different therapy options are, which now really include both biologic and small molecule therapies. And so, as I mentioned earlier, when we talked about his lifestyle, his work schedule, he really felt that ustekinumab was going to be the best choice for him. As part of that discussion, he mentioned that even before starting some of these medications, it's important to make sure that he's really up to date with all of his vaccinations, because many of these actually then make certain vaccines contraindicated because of the fact that they suppress the immune system. So it's important to coordinate with his primary care then to make sure he is in fact up to date, that we're all on the same page about which vaccines should be started now or given now before he starts his immunosuppressive therapy. And then also which ones are actually very safe to continue and to give, even if he is on a biologic or small molecule, and just make sure that he's up to date with all of those, because certainly anyone who's on immune suppression, it's important that we make sure we've reduced that risk of infection as much as possible.
Exactly.
And
so, yeah, the question is, so we want to keep them safe.
Yes.
So do we need to do that before they start the medication, or do we need to make sure that we're doing that after and continuing to keep those up to date? And so that close connection between the primary care physician and timing and the subspecialist is really critical for so many aspects of care, for the continuity of care, for that sort of extension by proxy of the love that I talk about, but also for all these little details that need to happen. A lot of times I'm just making sure that we may be the ones that help to follow up with getting some of the lab work done and doing some of the nudging and some of the other things that need to happen to support the plans for the subspecialist.
Absolutely. And again, I think also just recognizing that there were some barriers and challenges before, really just asking why. Sometimes I don't think we ask why enough. So it's like, oh, wait, I saw that you had some missed appointments before. Why was that? And then just kind of getting it, or you had some concerns about the cost. What's going on there? How can we help you with that? And so with Michael, we recognize an opportunity that, bringing in our social worker who's part of our team, just to kind of help make sure that we're reducing costs as much as possible, that we're utilizing any sort of patient support systems that exist as much as we can to his benefit. And even in the community space, recognizing what are those community-based social service organizations and opportunities for our patients, and partnering with them as well. It may seem like extra time up front, but I think in the long run, it really is a well invested use of everyone's time.
Absolutely. Absolutely. If he's healthy and well, then his quality of life and his amount time spent in the ER and back in your office is significantly less. And everyone's, like you said, it's a win for everyone. And a lot of times we know certain medications are going to be super expensive, but as a primary care physician, there's some medicines that, are always changing depending on the relationships with the pharmaceutical companies. And so one medicine that had been reasonably priced next month is $500. And I'm like, oh my gosh. And unless the patients feel comfortable telling me that, which a lot of times they do, sometimes they don't, I have no idea.
Right.
And so, I've had to be like, what? Okay, so let's find out what's the, medicine du jour for this antihypertensive, because that is ridiculous. They think that maybe I know, and so, and that I want them to still stay on it. They have no idea that I have no idea,
Right.
That's
a great point.
Yes. And so I have to do a better job of saying, listen, I prescribe these medicines, but I have no idea how much they cost. I don't even know what they look like most of the time. And so you have to help me help you get the best care for you. And part of that means that it's affordable, and there's so many options for many of the things that I treat you with. And if you can't afford it, then that's off the table.
Right. And a lot of the pharmaceutical companies, I think, because they know that their drugs are too expensive, do have some patient programs to help offset the cost for some patients that qualify. So it's important to be knowledgeable and aware of that, because they're, our patients, it's our job to know that, not our patient's job. And so making sure that we're taking advantage of those programs as much as possible.
Exactly, because there are some of those medications that don't have alternatives or a wide range of alternatives. And so we need to, be familiar, or have our social work be familiar with all of those patient assistance programs. So thank you so much for that case presentation. I am so thankful that it ended well for Michael, because it started out looking so dismal. And I'm sure our audience learned a lot. I know I did, about how to manage patients with IBD in a more holistic and interdisciplinary way. So let's summarize our discussion with our SMART goals. And those are goals that are specific, measurable, attainable, relevant, and timely. And that's what I hope you'll take away from this presentation and apply to your practice. So the first would be to assess your own biases and work actively to address them. Perhaps take the IAT and identify areas of improvement. 2, establish relationships with local healthcare providers to develop a more holistic approach to care. Identify care providers where you need extra areas of support, like social workers, GI specialists, PCPs, nurse practitioners, GI pharmacists, and reach out to them for collaboration. Integrate a checklist or tool to evaluate all patients for social determinants of health. You may create this tool yourself. We have something on our CMEO website. You can begin to ask questions regarding social determinants of health in all patients starting today. There are a lot of tools that are available to you. Prepare, CMMI has tools that are available. And then last, plan for equity when you're taking action. If you don't plan for equity, you're planning to fail, essentially. So look at the whole patient and share this educational program with your care team and meet the patient where they are. I want to remind our audience that here are some of the topics that we've covered so far. We'll be adding new content every month, so please visit the CME Outfitters Diversity and Inclusion Hub regularly to watch our educational programs and to earn your digital badge. The CMEO DNI Hub also has a number of resources and tools you can use or share with your patients. So thank you again to Dr. Sandra Quezada for joining me today and for sharing this space with me. I really have learned a lot. I'm so impressed and just honored to be with you and learn about the work that you do every day in your private practice and in your national space. To our audience, thank you for taking the time to learn with us. Please be safe and take the best care of yourselves so you can provide the best care for your patients, particularly our more marginalized and underserved patients. Have a wonderful day.